Welcome to the Scientific Sense podcast, where we explore emerging ideas from science, policy, economics, and technology. My name is Gil Eapen. We talk with world's leading academics and experts about their recent research or general areas of topical interest. Scientific Sense is an unstructured conversation with no agenda or preparation. We cover a wide variety of domains where new discoveries are made and new technologies are developed on a daily basis. We are most interested in how new ideas affect society and help educate the world how to pursue a rewarding and enjoyable life rooted in science, logic, and information. We seek knowledge without boundaries or constraints and provide unedited content of conversations with researchers and leaders who love what they do. A companion blog to this podcast can be found at scientificsense.com, and this podcast is available on over a dozen platforms and directly at scientificsense.net. If you have suggestions for topics, guests, and other ideas, please send them to info@scientificsense.com, and I can be reached at gil@eapen.info. My guest today is Professor Elizabeth Krupinski, who is Professor and Vice Chair of Research at Emory University in the Department of Radiology. Her interests are in medical image perception, observer performance, decision-making, and human factors. She is Associate Director of Evaluation for the Arizona Telemedicine Program and Co-Director of the Southwest Telehealth Resource Center. He is also the co-editor of the Journal of Telemedicine and Telecare and editor of Telemedicine Reports. Welcome, Elizabeth.
Thank you very much for that kind introduction.
Sure, yeah. So you have been researching and contributing to making telemedicine more broadly adopted for a long time. I want to set the stage with some definitions and perhaps use one of your research papers to start with. So it's entitled Clinical Examination Component of Telemedicine, Telehealth, mHealth, and Connected Health Medical Practices. And so telemedicine and telehealth in general are practices of medicine at a distance. You say components of a more traditional clinical examination are part of the telemedicine workup for specific conditions. What are some of these components and what are some of the technologies that we use for this now?
Yeah, so obviously you cannot do the same sort of physical exam virtually as you would in person. So there are some limitations, but there's an awful lot that you can do. And a lot of it depends on the sort of the setting that you're doing telehealth in. So for example, you've got to separate out the provider to provider type of telemedicine where, for example, the patient goes to a clinic in their, say, remote area, wherever they are, and at that site is perhaps a nurse practitioner, an APP, or even a physician who's a general practitioner. And then at the connecting site where the consultant is, you have either a subspecialist or, for example, if it's an NP or APP or RN or whatever at the site with the patient, you've got perhaps an MD or a DO at that other site. Now, in those situations, it's a lot easier to carry out a more traditional physical examination because you have a healthcare provider at that other site. And so they could, for example, take blood pressure, pulse. They could help with a physical exam, getting chest sounds using an electronic stethoscope. They could, for example, use an electronic or a camera attached to an otoscope, and you could look into the ear at the eardrum if the patient is having ear pain or down the throat or whatever. So in that situation, a lot of the components and the specialist at the consulting site simply collect that other healthcare provider to collect the information that they're after. Now, when it gets more difficult is when the patient is in their home.
Right.
Obviously, patients are not going to have any of the equipment. that a healthcare provider would. However, there are things that the patient can do. The patient can obviously, in all likelihood, has a thermometer, so it could take their temperature. A physician could direct the patient on how to get their
Yeah.
pulse. Could, if the patient has a home blood pressure unit, direct them through that if they don't know how to use it. There's information that you can get from a lot of apps these days, simply utilizing your
Right.
smartphone. There are electronic scales, Bluetooth connected types of devices that the patient could have in their house, or if they are an existing patient, perhaps they have been sent these devices or prescribed the devices
Mm.
almost, and the healthcare organization or provider could have loaned them or given them to the patient, and the patient simply has to, step on the Bluetooth scale, and that information is uploaded to the web through a patient portal or one of these online platforms that are used in telemedicine, and the provider could get them that way. Obviously, things like utilizing an electronic stethoscope on yourself as a
Yeah.
patient is much more
Right.
difficult. But as I said, there are increasingly apps and technologies that can either be provided to the patient or the patient may already have that makes a number of the core components of a physical exam
Right.
feasible. A lot, again, will depend on that patient. Um,
Yeah.
it does sometimes help to have somebody else in the room, especially if you're dealing with a patient with a chronic condition who may or not be capable of doing some of these things. An older patient, perhaps a pediatric patient, would obviously need a caretaker or a guardian of some sort to help with these
Right.
things.
Yeah. So the first modality where the expert is sort of a hub and spoke system, right? The expert is at the hub, and either a nurse or a consultant is with the patient in different locations, and making that connection. When the patient is at home, like you say, it's much more challenging. But we have enough technologies, right? We have sort of the home health a set of technologies that are rapidly developing. And so, even without the patient knowing, I would imagine in the future, the physician would be able to pick up a lot of the information just electronically.
Well, I hope with the patient
Yeah,
knowing, yes, because we don't
yeah,
want to
yeah.
have Big
Right.
Brother and these, hidden devices. But yes, I mean, they would be able to be a lot more automatic for the patient in the house. And there are systems now, like I said, that you can, the provider could, we call them suitcases sometimes. And, it's literally a suitcase with a number of these devices in
Yeah,
them that is sent to the patient in their home for them to use. Quite often someone will go and help them, understand how to use them and so on. And then after that, they connect usually through these systems or as systems on the side, and can very readily communicate with the provider and send blood pressure, pulse
yeah.
oximetry, quite often spirometer. I mean, there's a lot of these tools that are very easy to use or increasingly easy to use by the patient themselves.
Yeah, so as we get more adoption here, we're getting more data. So you have a paper, The Empirical Foundations of Telemedicine Interventions in Primary Care. This, I guess, is becoming more relevant in the pandemic as well. So you say, although there is no uniform and consistent definition of primary care, most agree that it occupies a central role in the healthcare system. It enables and supports patient-centered care, the medical home, managed care, and so on, population health. And we increasingly have shortages of primary care physicians, right, all around the world, not only in the United States, but all around the world. And so telemedicine, it used to be sort of an experiment, I guess, some time ago, but it's almost becoming a necessity in many cases, right?
Oh, absolutely. And it's kind of ironic that it took a worldwide pandemic to get people to suddenly, all of a sudden, see the value of telemedicine, even though literally it's been around for well over 30
Yeah.
years. And those of us who are in the field have been fighting for at least that long to get people to accept it and get reimbursement codes, et cetera. But yeah, you're right. Absolutely. It has absolutely exploded during COVID, and people are realizing the benefits of it. I do want to put a caveat on that because, a lot of the ways that telemedicine is being done now is a result of waivers that were put in place here in the United States and other countries that made the delivery of telehealth and connecting patients with providers a lot easier. For example, waiving some of the HIPAA regulations, waiving with respect to the types of devices and communication tools that people could use. So as those waivers expire and as we quote unquote go back to normal, some of these waivers are not going to be in place, and people are going to have to adjust and upgrade the technology and the tools that they were using to adhere to, various regulations. But I think we're going to be able to deal with that. And, some waivers are just going to expire. Some of them are going to be continued. And hopefully regulatory bodies and reimbursement agencies will actually leave a lot of this in place is what we're hoping. So telemedicine can proceed. Certain ones like, prescribing laws and narcotics, et cetera, those are going to go back to normal. A lot of the HIPAA restrictions and the similar in other countries are going to go back to what they were to some extent. You're no longer going to be able to use FaceTime or Skype, for example, these non-HIPAA compliant platforms. So people are going to have to adjust in that sense. But like I said, I think that, the cat is out of the bag on this.
Yeah. One. I also wondered, Elizabeth, I want to get your perspective on this. Is primary care settings more challenging for telemedicine because, you could have a large variety of, the patient could present with a large variety of symptoms and diseases. And to the extent that you don't have home-based technologies yet, and you are really diagnosing, and I'm talking about the second modality that you described, where the patient is calling from home, and you're really diagnosing based on observational characteristics. Does the primary care setting make it more difficult to do?
I don't know if it makes it more difficult. I think every clinical specialty has its own challenges associated with it. Primary care, I think some of the challenges there are, it is sort of that first line. And so, a patient coming in with a new set of symptoms or conditions that has not been diagnosed previously, there's only so much you can describe in a situation with telemedicine. I mean, at some point, you've got to get the blood work. You've got to get the urinalysis. You've probably got to get, imaging. Yes. So at some point, yes, the patient's going to have to go in and be seen in person. But I think, a lot of the describing of the symptoms, a lot of some of the early information can clearly narrow down the range of possibilities as it would in an in-person visit when the patient is just sitting there describing, what they're feeling and what their symptoms are. And just like in person, then, the further set of tests are going to have to be done. I think the limitation is that, this is okay and is probably going to be a lot closer to what happens in the clinic when it's more of a complex condition, a chronic condition, or something that absolutely requires more tests and information to really narrow down and confirm what it is. When you're dealing with some of the more, I don't want to say common, but I mean some of the common things like earaches, UTI, in a lot of cases, the physician obviously gets what the patient has, and especially if the patient has had it before. But it would be ideal, obviously, if they could look into the patient's ear, because you don't want to prescribe, to an 8-year-old, a bunch of, antibiotics if it really isn't an earache that can be treated with that. And so you do want to have that little bit more information. But like I said, there are increasingly things that you can, attach to your iPhone that allows some of these images actually to be acquired. There's certain ones that are being developed to do eye exams, literally, with your iPhone. So I think that, in some cases, it's just different
Different,
challenges. So
yeah.
no, I don't think it's more of a challenge. I just think they're different. If I'm going to be going to a radiation
Yeah.
oncologist, I'm not going to be doing that just for the fun of it. I'm going to be doing that because I am known to have, say, cancer, and I've already gone through all those preliminary
Right.
things. And I'm going to the radiation oncologist not for diagnosis, but for treatment. And yes, for the treatment per se, I have to go in, but a lot of that preparation and follow-up can be done via telemedicine. So in that sense, it's a little bit more protocol driven in a
Yeah.
sense than primary care, where you're faced with a host of things that quite often needs these ancillary tests and so on to really be clear of what the diagnostic differentials are and what the options would be to treat.
Yeah, so a little bit more uncertainty. So I wondered, specialty area like dermatology, for example. So teledermatology, where you could, observations is a big part of the diagnostics. Is that so? From an adoption perspective, where do you see more adoption happening, in more specialized arenas or in primary care?
Oh, that's an interesting question. To date, it has been a little bit more in the subspecialties, because I think, as I said, each one is so unique that the within the specialties it has kind of evolved, and primary care to some extent has been a little bit more of a challenge, for the reasons I stated
Yeah,
before. I think now, as a result of COVID, I think primary care has probably caught up a lot with a lot of the other
yeah,
specialties
yeah,
in terms of what's being done. And in the future, as we proceed, I think what we're going to find is a lot of work being done in primary care to, now we understand a little bit better what some of the challenges really are and what innovative solutions people have come up
right.
with to address those challenges. It's kind of scary to think, but I mean, we've been doing COVID now for almost 6 months. There's been a ton of innovation, and it's going to continue. And there are providers, there are PhDs, there are companies out there that are listening to what's going on, watching going on, and saying, hey, we've heard that this is a problem. They go off and
Yeah,
address it.
yeah. And you have another paper which is in a slightly different area. So best practices in video conferencing based tele-mental health, where you say the form of interactive video conferencing has become a critical tool in the delivery of mental health care. And you say it has demonstrated the ability to increase access to the quality of care, and in some settings, to do so more effectively than treatment delivered in person. Could you talk a bit about that?
Yeah, I mean, behavioral and mental health is and has been for a number of years like one of the primary examples of what can be done with telehealth. It is very amenable to it. I mean, if you think of what a lot of diagnosis and treatment is in mental health, it's talking with the patient. There are tests that are done, but those are usually sometimes imaging, so that certainly still has to be done. But there are a lot of tests that are either orally or written given, and you can do a lot of that online. And a lot of it is sort of the
Yeah,
talk of telepsychiatry, telepsychology, social work, and so on. So it is very amenable to telehealth. And there are some instances, yes, where having that remoteness between the patient and the provider actually
yeah.
helps. There are some patients, just example, an agoraphobic,
Mm.
who's terrified of leaving their house. Well, they're terrified of leaving their house, so getting them to go to their provider in person, it can be a challenge. Yet doing it virtually, they don't have to leave their
Right,
house.
right.
There are circumstances with victims of abuse,
Mm.
where having that distance, that physical distance between the provider and the patient is a benefit.
Right.
There are certain patients who you might not want to do. If a patient is actively hallucinating, or actively in a state where they believe that their computer is watching over them and the aliens are coming after them, you hook up with your provider by the computer, they might not really be amenable to doing that. They may actually incorporate that into their their mental framework and so on.
Yeah, and some cases, Elizabeth, it's also the timing of the intervention could be also critical, right? We think about suicidal type issues, that if you can actually reach the patient a lot faster remotely, that might be very beneficial.
Absolutely, absolutely. And with any, in any circumstance where the patient is going to decompose, whether it's a mental problem or, a cardiac problem. I mean, there's a lot of technologies that can be used to help monitor these patients. There's apps that have been developed, for example, by the VA that keep track of, patients' mental states, physical states, and so on. And they can send out alarms.
Yeah.
That tell the provider, hey, there's something going on with this patient. For example, there's, apps, assuming that the patient has their phone with them, or even sensors that can be put on the body that indicate when the patient's moving, when they're getting up, getting out of bed, and so on. So if you've got a patient with a mental or behavioral health problem, and you're monitoring their activity, and you note that, for the past 72 hours, this person has done nothing but get up and go to the bathroom. Right. That might be a sign that, it's time to reach out, because that person is basically sitting in bed all day, and that is not healthy. So yeah, they're combining sort of this remote monitoring technology with the telemedicine interventions and ability to connect. Absolutely, there are ways that we can intervene a lot earlier and potentially prevent admissions to the hospitals, readmissions, relapses, and so on.
Yeah, it's interesting. Long time ago, it used to be that the physician went to the patient, right?
Yeah.
And nowadays it's always the other way around. But it seems like we are coming full circle around that, which is now the physician knows when an intervention might be optimum, and without the patient taking an action, could intervene at the right time with this type of technology.
No, that is absolutely correct.
I want to just go into another area. So you have a paper, Detection of Breast Cancer with Mammography, Effect of an AI, Artificial Intelligence Support System, where you compared breast cancer detection performance of radiologists reading the mammographs compared to what an AI, artificial intelligence system would do. What did you find in terms of reliability and usefulness?
It wasn't quite comparing the radiologist to the AI. Yeah. It was actually a type of artificial intelligence where what the mammographer was able to do is they would bring up the case, the 4 images that are typical of a mammogram. Sort of the two views in the 2 breasts. So you have 4 images, and they could then read the images because, in my opinion, and the opinion of a lot of people, including the FDA, the radiologist should always look at the images first without any decision information from any computer system, whether it's computer-aided detection or discrimination or any of these AI tools. So you look at it, and this particular scheme that I was the company that I was working with on this one, basically what it allowed the radiologist to do was 2 things. One, they could either just click a button and the AI prompts or cues would come up on the right on the images and say, it would indicate where the computer thought a mass and or microcalcification was. The radiologist could do that, or they could also just look at the image and point with the cursor and click and say, okay, AI, what do you think is happening here? Right. And the AI could come back and, 0% or, okay, there's a 20%. And so we were not really looking at the performance of the AI. We were looking at the performance of the radiologist, in a sense, with and without the AI. So we had to make an initial decision. without the AI, okay, now go ahead and access and see if that changes your
Right.
decisions.
Yeah. And what was the conclusion when AI aided a radiologist in their job? Was there an improvement?
Yeah, I mean, overall, we saw that there was some increase in
Yeah.
performance. A lot of the tools that are developed and using computers to help diagnose images, especially in mammography, is not new. We didn't used to call it AI. We used to call it computer-aided detection and
Right.
diagnosis. And that's been around for almost 20 years, actually. And it was actually a lot of the early schemes that were developed by some of these companies are already being used. They're FDA
Yeah.
approved, these older computer-aided detection, and they actually get reimbursed for using them. A lot depends. So, and it's being seen in AI as well. A lot depends on the experience of the
Yeah.
radiologist. So, a resident, a fellow, someone who has been, practicing for only a few years, quite often benefits
Mm.
more from the AI input than a well-experienced mammographer or other type of radiologist, depending on, what types of images they're reading. Sometimes it depends on the
Yeah.
setting where the radiologist is. So an academic radiologist may not be impacted as much as a general
Mm.
radiologist. A general radiologist reading all sorts of images is often found to benefit more from computer-aided
Mm.
tools and decision tools. So it just varies, but overall, it does seem, at least with the scheme that I was using, that the radiologists were actually, their decisions benefited from the input of the AI, and it didn't take excessively much longer for them to access and utilize that information.
Okay.
So it fit into the
Yeah,
workflow.
but did you find, I don't know if you measured this, Elizabeth, but did you find any difference between experienced radiologists and those, who are just getting into the business? I see two things there. One is experience, of course, and the other is perhaps the younger radiologists are also potentially more comfortable with this type of technology too, right? I was just wondering if you picked up anything.
These days, I think all radiologists are very comfortable with technology. I mean, we've been using PACS, digital technologies, workstations for, gosh, 30
Yeah.
years. Those, and there's even, a lot of the older radiologists that are still using, that did learn on
Right.
film, and were using film for part of their career. They're all using digital now and have been for any number of years. So in the early days, I mean, some of the early studies I did back in the early 1990s in radiology and actually in pathology showed just
Mm.
that some of the older radiologists actually did better with film or light microscopy than they did with digital radiology or digital pathology, and the younger ones did better in the digital formats. By the end of the 90s, that was just gone.
Yeah.
The digital skills of even, the older, more experienced radiologists were the same as the younger radiologists. In terms of the acceptance of AI as a generational thing, it's different. I don't think we know
Yeah.
enough now, but I know there's enough of the younger radiologists who are just as
Mm.
cautious about the utilization of AI. There's so many things about AI and its implementations that we just don't know enough
Right.
about. Generalizability, the biases that are inherent in the
Right.
AI, just so many things. Just generalizing from one institution to
Yeah.
another, utilizing different types of equipment. If the AI is trained on X company's images and then you try to do it on Y company, the results change. Different populations of patients. If I do it, in the middle of Iowa on those types of
Mm.
patients, then compare that to say Northern California. Wow, all of a sudden the algorithm doesn't perform
Right.
as well. So we just don't know enough now to say how effective it really is going to be in the long run.
Right. Right. Yeah. So technology has to improve there. There is also potentially, as we go forward, there could be data coming from different avenues. And, we see humans are not really very good when there is a lot of different types of data. to combine that to make a decision. You have a paper not on that particular topic, but something related. Impact of patient photographs on detection accuracy, decision confidence and eye tracking parameters in chest and abdomen images with tubes and lines. So this is a physician actually using multiple types of images to make a decision.
Yes, actually, so you've got your this is in radiology, and what we did was one of my colleagues, Srini Trindanapani, he's an MD PhD who was formerly at Emory. He developed this system where, as the patient is having their image acquired, and this is primarily with the traditional film images, although the goal is to expand it, for example, to CT, to MRI, and so on. But as the patient is getting their images acquired, say, for example, a chest x-ray, it would simultaneously acquire a photograph of them. And so if you think of a patient in the hospital, they have all these, they have feeding tubes, they have breathing tubes, they have all these monitor wires going all over them and so on. And all that stuff appears on the x-ray.
Interesting, yeah.
But the problem is the patient and all these tubes and things, they're three-dimensional objects. Right. When you get the x-ray image, it's a two-dimensional image. These are not volumetric like a CT or an MRI. Right. So quite often it's difficult to say, is that piece of wire or tubing inside or outside the patient? Right. And sometimes it's very difficult to tell. And, they have to follow the lines and, look at the image and try to make their decision. The idea behind the photographs is now I have a photograph showing the patient, and there's the tubes, there's the lines. Oh, they're outside. They're sitting on the patient outside. Oh, that feeding tube is there. Yes, it actually is, inserted, into the patient. So the goal of the photographs, yes, was to be able to use these different sources of information to make these decisions, as well as in another situation is to make sure you've got the right patient. Sometimes when you acquire an image, somebody inputting the information could make a mistake and enter the wrong digit. And all of a sudden in the system, it says, this is Mr. Smith, but in reality, it was Mrs. Jones.
Right.
And so you've got this image that's obviously of a woman, but you're looking at the information and saying, well, now it says it's Mr. Smith. Let me look at the patient photograph. Okay, yes, this must be in the system incorrectly. Let me, try to get this solved and, get it in the system correctly. So it helps in that sense as well. It also helps in when you've got right-left errors.
Right.
So, for example, it might say, the patient has fell down and their left leg hurts. And yet you're looking at the patient image, and clearly it's their right leg that's full of blood and the bone sticking out. So it was a mislabeled image in terms of left, right side. So there's a lot of uses of these images. We have it here at Emory. He moved to another institution. They're using it there and a couple other pilot sites. The goal really is to try to promote this so more and more institutions use it, because the more information you have, the more valuable it is.
Right. Yeah, you say that if the photograph is large enough, it just takes an average of 3 extra seconds to view compared to the radiograph alone, but it adds significant confidence to decisions. So that's significant.
Yeah, no, and that particular study, what we were looking at is, the radiologists are looking at these images on computer workstations and computer monitors. And, it's like real estate, location, location, location. You've got to have we're adding a piece of information, a new image, to what the radiologist has available. And so the question is, how big should that image be? So we use kind of a large, medium, small, the 3 bears and Goldilocks. Yeah. And we track their eye motions to see how often they looked at the images, how long they spent, and so on. And there was an optimal image size where they were able to get the information in a quick and efficient manner, those 3 seconds, and at the same time, that information was valuable and helped raise their confidence in their decisions. Whereas the smaller image, or if the image was too big, taking up too much information, too much of the real estate, it interfered with the chest X-ray itself, and so there was an optimal size that we had.
Yeah. I want to get into, you have a group of papers, Elizabeth, that relates to fatigue, ergonomics, things like that, right? So the first one is the impact of fatigue on complex CT case interpretation by radiology residents. You're looking at how fatigue affects the reading, right, of radiology residents.
Yep.
And what did you find there?
Well, that's actually our latest study in a series of quite a few studies that I've been looking at this for about 12 years now. And early on, when we started out doing this, the first, how I kind of got into it all was, I would do eye tracking studies for a variety of purposes. And sometimes I'd have radiologists come in after lunch or late afternoon, and I was finding it was very difficult to track their eyes. And I was sitting there, well, what's going on? And it's because they were tired. And so their eyes were kind of, closing too much. And you can't record somebody's eye position if their eyes are closed. And so, I started to think, wow, I mean, they're tired. They're working a lot. And, when I talked to them, they said, yeah, I mean, it's complex. It's hard. Reading is difficult. It takes a lot of time. And yeah, it is fatiguing. And so I said, okay, let's find out, is this an important phenomena? Can we measure it? And does it impact performance? And so we early on found ways to objectively measure fatigue. And then we started to do the studies on, does fatigue impact diagnostic accuracy as well as time to interpret images? And in the early studies, I used both radiologists and residents. And for both of them, yes, we found significant decreases in diagnostic accuracy as a function of the number of hours they had read prior. So first thing in the morning when they were fresh, having read, no images, performance was significantly better than reading late in the afternoon after having spent a whole day in front of a computer reading images. And it was about a 5% difference in performance on average in accuracy. And it was in both false negatives and false positives. In other words, the number of false negatives increased, so they were missing more lesions, and the number of false positives increased. They were making more false alarms. And overall, it impacted experienced radiologists as well as fellows and residents. But surprisingly, the fellows and residents were often more impacted than the older, more experienced radiologists. And when we went into this, we were all thinking, it's going to be the older ones who are impacted more. And then it was the younger ones. And we're like, what's going on? And what we kind of figured out by talking to them and to radiologists is that being a trainee is incredibly difficult. It's exhausting. And they're actually more fatigued overall than the radiologist, simply because of, the stress of being a trainee, the difficulty, the learning experience, and so on. And so in this final study that we did with the CT, we only used the residents. And again, we found that diagnostic accuracy and efficiency, the speed with which they look at a given case or image and make a decision, both of those are negatively impacted as a function of fatigue.
And just for my understanding, Elizabeth, you said that the younger ones show lower numbers there, both efficiency and efficacy. So as the first year residents are worse compared to the last year residents?
In this study, we didn't use first years because it was CT, and they don't really do a lot of independent reading. But we did have the third and fourth year residents typically are more efficient and make fewer mistakes than the second years. And I'm sure if we actually did the first years, we have done first years in other studies. And yes, typically as you get go through residency from first to your fourth year, you do become less impacted by fatigue, and you're making less errors overall. But the fatigue still makes you make errors. But as you get better, see, the thing is with experience, just in general, you're better at reading images. But I think you also learn the tricks of the trade. You also learn the signs of fatigue. You understand your limitations better. And you also, as you then go into real practice as a practicing, board certified radiologist, you learn to hit, when you hit that wall, you get that second wind.
Right.
And they learn how to recognize that they're fatigued, and then how to, I got one more hour, I got these more cases here, I got to pump myself up, let me move around a little bit, grab a cup of coffee, here I go, I'm ready. So they learn ways to overcome that fatigue. At some point it catches up. I mean, you can't read 15, 16 hours a day and not expect fatigue to have an impact. But I think in that time range of, 8 to 10, 8 to 12 hours, there you can get that second wind. And then beyond that, I think everybody is going to be impacted.
Yeah, so you have a related paper here, the impact of fatigue on satisfaction of search in chest radiography. And I guess the satisfaction of search, this is getting into the process, right? So you are reaching a conclusion a lot faster and making errors in that way?
No, satisfaction of search it's a phenomena where when there's multiple findings in a case, you find one and then you miss the other one or ones because you have, quote, satisfied your search. You found something. And so it happens. It's not, it's a kind of error that's made in radiology. It, happens periodically. It doesn't happen a whole lot, but it does happen. And what we found in this study was that when you're fatigued, you're more likely to make this error, to miss that second and or third, fourth, whatever lesion, than when you're fresh. When you're fresh, you're more likely to continue searching for additional findings after you find that first abnormality in the image. But when you're fatigued, it's like, oh, I found something. Oh, good. Let's just go to the next case.
Right. Yeah, I don't know if I'm reading this correctly. You say satisfaction of search reduces both true positives and false positive responses, whereas fatigue reduces true positives more than false positives. Is there any implications there, or just an observation?
It's a sort of more of an observation. We'd have to do more study on it. Essentially, what it's saying is that, with satisfaction of search and fatigue, it's a double whammy. You're even more prone to miss additional lesions once you find the first one. The interesting thing was that when you're fatigued, you make some more false positives, but really no more than in the traditional satisfaction of search situation.
Okay. Yeah, so I want to close with another paper, Optimizing Ergonomics in Breast Imaging, where you're looking at radiologists sitting in front of a workstation for long hours and getting into repetitive strain injuries and the computer vision syndrome. You want to talk a bit about that?
Yeah, so, the mammographers are similar, of course, to any other radiologists, but there's also some differences in what they do. And mammography, when you think of it, is the majority of, there's a lot, it's a screening modality, first of all. So we're screening women of, all ages, annually. And the vast majority are normal. And so when the mammographers are reading the screening cases, and I separate that from the diagnostic cases because they're different. The screening cases, the majority of what you're going to see is normal. Yet you have to do the same thorough search as you would for an abnormal image because you don't know. in advance, whether the patient's normal or abnormal, where you're going to have a mass or a microcalcification
Right.
or what. And having that majority of cases being normal is very different than, for example, going through chest x-rays or abdominal, where the likelihood of something being there is much, much greater. And so mammography is actually, I think, more fatiguing perhaps than some of these other modalities and types of imaging where there's more variety in things to find, and there's more likelihood of finding things. So mammography in the screening situation, I don't want to say that it can be boring, but it's a lot more difficult sometimes, I think, and I think a lot of mammographers do as well, to kind of stay at that high level of motivation. I mean, they do get in this zone, but I think fatigue probably impacts them more than others. And so this study was looking at sort of some of the general features of, what is it about mammography, and we just happen to use those as an example. But I mean, radiologists in general, they're sitting for a long time, they're staring at computers, they're in a relatively dark room, trying to go through these images and so on. And yes, it can lead to not only computer vision syndrome, so the eyes obviously are going to be affected by all this, but your back, your neck, your buttocks and hips just from sitting all day, plus just sort of that mental fatigue from staring at images all day, and most of them are normal, and it's just an overall environment that can create a lot of fatigue. And so that particular study was looking at some of the contributing factors and what we could do to improve the situation from an ergonomic perspective, to improve the work environment for radiologists that would help them avoid some of this physical and cognitive fatigue.
Yeah, it's so interesting. So you have looked at a lot of different type of images, different type of processes. Would you say, Elizabeth, based on all your research, that the more the chance of fatigue, the higher possibly the application of AI-related technologies that might improve performance?
That's what a lot of the AI developers are thinking, and I think that it certainly does have potential to improve that. If we can develop schemes that will eliminate some of the difficulty of some of these images. For example, if you could get an AI scheme that could effectively triage a lot of the normal mammograms or the normal chest x-rays that come through, and do it at a rate that would be clinically acceptable and socially acceptable. So take these images, triage them out, and then maybe the residents review them rather than the radiologist. And so what you leave for the radiologists are the more complex cases, the more interesting cases. And I think, yes, that definitely does have the potential to eliminate some of the fatigue. But I think you've also got to be aware that that also changes things in terms of potential biases and expectations. So like in the mammography case, let's say 80% of the cases in a screening situation are definitely normal. Okay, so you take in right now, the radiologist sees all these cases knowing that 80% are definitely normal, and 20% I've got to concentrate on, because a good percentage of those, 8 to 10% are going to be definitely abnormal, and then there's some, those middle ones that you got to really look at. Now with AI, suppose the AI triages out that 80%. So now I'm left with that 20%, and now that 20% is 100% of what I'm looking at. I have dramatically changed the expectations because I changed the prevalence of disease. So the radiologist has to readjust now and say, okay, it's no longer, 20 out of 100 that I've got to, really concentrate on. I got to concentrate on all of these.
Right, yeah.
And, even if I've got AI that's going to help me with these, it's still gonna you still have to readjust the way you think and your expectations and your reporting criterion, because it is a very different situation cognitively than it was compared to what we have now.
Yeah, maybe one way to handle that might be to assign a score, which naturally happens in an AI system. So every time you pick up something from that red bucket, it also has an assigned score to it, a probability of finding something in there. Perhaps.
Yeah, those are things that people are
Yeah,
looking at. And to be honest, I don't think we have enough data yet to know the best way
yeah,
to do this triage or the indication of what the AI thinks. I mean, should we put a big circle around what the AI thinks with the probability, hey, I think this, the computer thinks this is 80% likely to be abnormal, and I think it's going to be a pneumonia. I just don't think we have enough studies yet to know how the best way to incorporate AI into the
yeah,
workflow is going to
yeah,
be.
yeah.
We need a lot more
Yeah, the good
study.
thing is that the technology is improving. You and others are doing research around this. I think, like you say, more research is needed, more studies are needed. So hopefully we'll get there. This has been great, Elizabeth. Thanks so much for spending time with me, and
Thank
good
you.
luck with all your research.
Thank you so
Thank you.
much.
Bye.